That's me. That's good. Perfect. Thank you. You want to test it? Or
Yes, sir.
you'll
We're
test the sound?
testing it right now.
Okay, perfect.
Sean, I just gave you the second angle. Doctor, I want to look at those screens, Sean.
Yeah, looks good.
Yes, sir.
Might go in closer when we get to it.
Yes, sir.
Sorry, Dr. Al, you want me to move this closer to you, or?
No, I see that fine. No, I'm at the camera
Yeah.
closer. Can it zoom in a little bit?
Yeah.
Transitioning now.
That's better.
Dr. Allen.
That's better. Let me look here. Okay, and turn to your left a little bit for me.
Does that look good, Dr. Al?
Yeah, that I think is going to be good there. That's better there.
Okay.
And if you zoom in just a touch. Let me put, I need this. Bring the chair down though.
1 second.
Okay.
How about that, Dr. Al?
That looks good. I like the one before that better.
You like the one before that looked better?
That's, yeah, that one. That's good.
Sounds good.
Okay.
Okay, let's make you numb.
All right.
You want to not show this part, process, right?
No, don't show this.
Okay. Logo.
Let me just see this a minute, see what this. Yeah, go ahead.
Okay.
Mhm.
I'm going to dry the surface and I'm going to put some topical on. And I'll put this viscose on top. And you can just close and rest for me just a minute.
Yes, y'all can go. You're gonna see the logo. The number. Yes, sir. Go ahead. Go ahead.
So you're gonna have a quiet weekend coming too?
I don't know. I have to babysit tomorrow.
Oh, do you?
Uh-huh.
How old a babysit?
1.
1 year old?
Mm-hmm.
That could be challenging.
I'm bringing a friend.
I'm sorry?
Bringing a friend.
Oh, good.
Yeah.
Yeah. I think that'll be pretty good. Now just give me a little tingle down there, make the injection. You've had the injection, you know what it's like. Feel a little bit. Okay. Now you can feel a bit of injection here, no sting. That looks pretty good. See over here. Turn toward me. Excellent there. Let that take hold a bit. You can close.
Doing great.
Great. I forgot to turn my ringer off on the phone. Is that going to bother you if it rings?
Where is it?
It's
Probably
right
in
behind
purse.
you.
Is it inside there?
Yeah.
Or maybe they can just move it to another room,
Okay.
if that's okay.
Yeah, that'd be great.
Could you do me a favor?
Yes.
Could you pick up this handbag?
Handbag.
Yeah, it's ringing now. Yeah, and bring it over here. Just put it on that counter.
Oh, okay.
That'd be great. That way we won't hear it. You know what happens is our telephone here in the office rings sometimes.
Yeah, exactly.
Oh,
It interrupts it.
no.
Yeah.
Everything starts ringing.
Okay. And close and relax. I need to put a little, get you up over this a little bit better. Tuck it under there.
Everything
I can.
tucked in
There
just
you go.
right.
Yeah, you can't control your lip and have keep close because it's numb. I'm gonna give you a little bit on the other side of those teeth, and we'll be ready to start here in a minute.
Okay.
Okay, just turn toward me now. Turn way toward me. And you're gonna feel a little sting here. You don't flinch, so it's hard to know if you feel anything.
No,
Not too
that's
bad.
patient.
All right, perfect. So we're looking good. We're going to treat a lower right, just two tooth area, two premolars. Have a look here and show you, and turn to your left for me. And I think I'll do this. And what we have is, and turn a bit more to your left. There we go. And you see recession on the two premolars, also on the canine, also on the central. But this is actually closed just a little for me. I see that a little bit better that way. This is all class 3 recession, proximal root exposure. Really nice thick gingiva in the anterior, also on the canine. But here at the first premolar, you see there's no attached gingiva. What's there is thin and delicate. And it's also class 3, loss of papilla fill. So for root coverage, we may get 50%. But the goal here is to thicken the tissue. It's even weaker on the second premolar. A little bit of root effect. Might be able to plane that just with curettes. And then at the molar, the tissue is really thick. There's a bit of a notch here. And we may address this a little bit to just bring this tissue coronally. I don't think we need to include it with the graft because the tissue's thick here and the bone is thick. Commonly you see recession on the first molar mesial root because it's generally more prominent. It comes in at age 6, it's called a 6-year molar. So this tooth often has no bone there, so we would include that, of course, if that were the case. But here there's thick tissue and thick bone, just thinness at the premolars, not too unusual. So we've already anesthetized. We did mental block first and then some infiltration. So our next step will be to clean these teeth, and I'm going to see if I can have you turn a little more to your left to see if is that still comfortable for you. And if you can bring that there with a good view, I think. So I'm using a Younger Good 7/8 curette. I'm going to clean everything and scoop out the sulcus. I'm not including the canine with a graft, but we will certainly be including that in the site prep. So once again, it's a Younger Good 7/8 curette that's really good for root planing. Is that showing okay? Because it's behind me now.
Yes.
And there's some deposits here, so we're getting those off the root proximally as well as facially. Doing okay? If I bother you, let me know.
Just a tiny bit, but
Is that better? Let's see if I can get a different position here. Let me let you turn a little more like that. Can we get that in view now? Yeah. Okay. And the root prep is really probably the most boring part, but it's a very important part. I'm freshening the root here. There's just a little bit of abrasion to the root, not much. It's not an issue. Get just a little better position. Shannon's keeping this moist for me. Such a nice curette, Shannon.
thank you.
Let's see if I can show you this second premolar better. Okay.
Perfect.
And I'm going to change my position. I may block your view. Let you have a little break from that too. And close it a little bit for me.
Mhm.
That's good. Close it a little bit more if you can. But yeah, don't bite my finger though. So I can't close anymore. If I close anymore, I'm going to bite your finger. And of course, you want to not over prep the corona border, mostly just cleaning.
Up, down.
Yes, sir.
They're blocking the shot.
Yep. And let's turn you here again. And see if we can get that view in. Try to see if I can do it with this, but maybe not. Once again, just mainly cleaning. And as I was saying, not over prepping the coronal aspect of that root because it's not going to be covered. And see if we can get to that molar. Does that show now?
Great.
And I'm going to come in a position. You may not see me or see what I'm doing. I'm just going to finish that replanting on that molar. They're totally blocked.
Nope. Mm-mm.
Yeah, I think when you're getting in a position to see it, maybe your head blocks the light a little bit. You can go blind, can't you? You can operate without seeing. Okay, and I'll turn you again in that position. Thank you. Looking pretty good. Okay, now we're going to floss. I'm happy with the root planing. There was not a lot of reshaping to do there at all. A little bit, but mostly cleaning. And now we will floss to make it a little cleaner as well. And now apply EDTA, it's 17% EDTA, and this removes any smear layer, and also any micro islands of, I got it, I think, of calculus. Can you block that for me?
Please close down just a little bit.
Close a little bit for me? Can you close a little bit? Can you close a little bit?
Yeah.
There we go. Right, there we go. So this is just 30 to 60 second application of 17% EDTA on the teeth that we're concerned about. And concerned about all the ones that I will separate, just not wanting to drive any bacteria down into the tunnel. So you do all the teeth at one time. It's not necessary to spend a minute per tooth and go one tooth to the next and spend 5 minutes. So this will kill the bacteria as well as clean a little bit on the teeth, removing any, like I said, the micro islands of calculus, and we'll rinse this with normal saline to to finish that effect. So I'm pretty happy with that. And trying to touch more. Okay, left. Okay. And I'm not fond of this. I don't like the retraction with the mirror or with the optic gate that we use because it distorts the tissue a little bit and can compress some areas. I'm going to try to give you a good view of everything without using that. Kinder to the tissues for me. So our first step is to detach the tissue from the base of the sulcus to the crest of bone. We're treating 2 teeth. And if you can help me with holding this lip out here, we good.
Do you want the,
Yeah, we're going to put a bite block in first, just for comfort. The bite block is so you don't have to hold your mouth open. You can just hold closed against it. It's usually more
Oh, okay.
comfortable because I'm going to put a little pressure on the lower jaw, and that way you don't have to try to fight that. Just
Okay.
stay closed against that gently is sufficient. And open, and we'll put that on your left side.
you can just rest on that, right?
And after you get set there, if you can hold the lip down in front for me.
Sure.
Thank you. So tell me if we're seeing, because I can't see the monitor.
You might lean towards me a little bit. That's great.
Is that better?
Mm-hmm. That's perfect.
So this, you just walk it around. The sulcus, just kind of take a stroll through the sulcus. And if you glide down the root, then you can feel your way to the crest. You can tell when you hit the crest. I may block your view a little bit, just getting my finger rest in the right position. I don't need to do the distal of the molar because we're not including the molar in the graft. I might advance it coronally just as part of the procedure, but not with the graft. And it doesn't need much coronal advancement. So I think maybe you can see in this view the angle of the instrument to the tooth root. So you just glide down. And there's not much osseous dehiscence here. Sometimes there'll be a significant dehiscence, so you might glide down 5 or 6 millimeters. Here it's about 2. You want to go all the way over to the palatal line angle, root line angle, so that you're separating the papilla from the tooth proximally as well as detaching the tissue facially. I'm just going to retrace this buccal surface again, may block your view a little bit. And turn to your left a little more. I think it gives you a better view, thank you. Going all the way over to the lingual, again to complete that proximal detachment. This papilla looks like it could be a little bit weak, so I'm being cautious with it. It looks like there's a tight contact. Usually that will be on the lingual surface. You can see that when you check lingually. And it's not uncommon around the canine, particularly mesial canine lateral incisor area. There commonly is a real tight contact of the roots. I'm just going to retrace this area and see if it's good. And let me see a probe, please, for a couple of reasons. I'm going to check this space. Now, see, I can get through here pretty well, and certainly really well through here, really well through here. So the papillae are pretty good. This one's a little close. It's a little narrow, but this is reassuring that you can pass that through. Here, could too. This is one that often is tight. So that's one way you can check the integrity of the papilla. So we're going to measure the distance of graft, amount of graft that we need. And I'm just going to compress this for a moment. And we want this graft to go completely under the papillum, distal to the premolar.
Okay. I'm gonna swallow.
Hard to swallow with a bite block in your mouth,
Yeah.
isn't it? And you can hold that lip down in front when you get ready. And this is measuring 11 millimeters to that point, and another, I'm going to say 7, so I'm going to go 8. So I'm going to say 19 millimeters for this site. And my next step is to do the blunt separation and turn to your left, wave to the left. I need you to tell me if this is showing because I might be blocking here.
Perfect.
So you just do a little bit at each tooth. You can see I'm sliding under that tissue rather easily here, mobilizing this. And what I'm doing, if you can see here, and can you plot that for me because it'll show a little bit better. I'm going to parallel the curve with the root, and then I lean back and slide under the tissue, and I don't disturb the margin much that way. In other words, I don't stretch it or run a risk of exceeding its strength. So I'm down pretty far under here, about that far. We can expect undercuts at canines. Is this showing now?
Yes.
And I'm going to move to the second premolar. And just compress that. We'll take that for a moment. And let me see the elevator again, and go do the second premolar. Hold the lip down for me when you're ready. Oh, you tried to trim the graft. Okay, go ahead and trim the graft. I'll do the lip. I'll do unassisted for the moment. And I might be blocking your view there just a touch. Maybe the gauze give you a little better view of it. This is a moist gauze so that you don't dry the tissue, as Kevin spoke about. So going underneath this papilla and working toward the second premolar a bit. So I want to detach the facial aspect of the papilla on each of these teeth. I'm just extending around the canine a little bit. You can see how that moves already on the premolar, even on the canine a little bit. So I'm able to advance that tissue without really, just barely started the site prep. And what I'm doing now is I'm working toward that second premolar from the first premolar. So that's where that instrument is. And am I blocking here?
No.
Good. Having a hard time swallowing with that
Yeah.
cheek retractor in. We'll take that out in a minute because I think this is the. In fact, let's just take it out and see if you like it better without it.
Oh, yeah.
Bitter? Okay,
Uh-huh.
good.
Now, there's going to be some pressure, so just see. That's strictly for your comfort. It's not for me. And I don't know, this may be where I blocked your view.
No.
You want to be really cautious at a molar like this because you have a nice thick zone of attached gingiva here. And then you have the mucogenital junction. And then you're working to get this dissected, and sometimes there's a little bony ledge there at the furcation, and you're working over it, and you can perf right there at the mucogenital junction. So you just want to be aware of that.
Blocking just a little bit.
So I'm coming back through the premolar, working my way toward that molar, and you can see how I've moved that pretty well on the distal aspect of that papilla at the mesial of the molar. Hand me the posterior elevator. I want to show you about how we use that. And show you the point. And then if you aspirate that a little bit so it'll show. So I'll come in here in the sulcus and tell me that's showing.
Perfect.
And just glide. So I'm gliding toward the premolar. And that just does a really nice job of detaching that. In fact, I can do a little bit more of this because that furcation is a little bit irregular. So I've freed that up really nicely with this posterior elevator. It just reaches it really well. So we'll go ahead and advance that tissue. You can see how that advanced nicely. It's advancing nicely on the second premolar, pretty much on the first premolar. But I need to do a little bit more here. Sometimes I can even use this posterior elevator at the canine.
Kind of out, take the bees out of the camera.
Out of the camera view? Okay. Can the camera catch up with me? Can you see the canine for me? Can you see my instrument? Yeah, you got it there. Okay. I'm going to use the regular elevator there just to get a little bit more. And we don't need much here. I don't expect root coverage or need it here. You know, I talked to you about complete root coverage being overrated. Another place you could perf is at an undercut of the canine. There's an undercut right there. It should be pretty obvious. So you want to be aware of it and careful. I'm going to come from a little different angle. I hope you can see. Tell me if I... See how you can see that instrument through that tissue? That's what Willie was talking about. He likes the black line, which is what I'm using because you can see that instrument through the tissue a bit. So we have pretty good movement of the canine, not that we need that. Pretty good facial separation of the papilla between the canine and the first premolar. So I'm just tracing that area, all that area again. And I think we have nice movement everywhere. So this comes up really quite well. Again, I don't expect complete recovery, but we're going to give it a chance to get as much as possible just because I think it's better. And now we will do the arrowhead. Actually, let's do the papilla next. That's what we need to show that really well. Can you turn to your left a touch more?
Mm-hmm.
Yeah. And are we showing okay?
Yes.
So what you want to do is use the blade against the root like you were going to clean. You'll slide into that sulcus, and you can go down and touch the crest because we separated it. So I'm in there like this, curving in, but under the tissue. Then I turn the tip of the curette or the toe underneath the tissue to touch the second premolar and just course back to the facial. So I'm just swinging back underneath that papilla, not picking at it at all, and that separates it so it will detach. I need to be really careful with this one because it's a tight space. That moves, and then at the molar we should have a good one. So the blade against the tooth, course over to the lingual, turn the tip of the curette to touch the molar, come back to the facial. Let me see the straight elevator. I feel like there's a little catch at the papilla of the facial aspect, the more coronal border of the facial aspect, which means, I'll show you here in a second, that right here there might be a little catch, so I'm just going to check that. That seems to move really nicely. This one does too, and this one I'll be careful with. So I like what we have. So we'll place a graft after we do the rest of the dissection. getting close. And I'm going to use the arrowhead, the Shannon arrowhead, and just drop that below the sulcus. Turn to your left a little bit. And just check and see if we have any little attachments that would block the passage of the graft. And this is a site that I would think that if you haven't had a lot of experience with the tunnel technique, it's a good site to start with. I'm meeting a little resistance here. Draw that out slowly. I'll slip this arrowhead under at the canine and just make sure that that's clear enough for the graft to make it over that papillary bed completely without interference. And draw that out slowly. Look at the molar here. That's very good at the molar. Keeping that bend of the shank right about the CEJ at the second premolar. And that should be a pretty nice site prep. I'm going to check it with the modified ore band, just make sure that I've got every little attachment. I believe I did. Be extra cautious with this because it's just the last 3 millimeters of the shank that are dull. So the blade itself is longer. And that feels good. So I'm happy with that. So that's the site prep. Have a good view of that. And turn to your left a touch more. And now then we will isolate with gauze and insert the graft. So in the isolation, I'm putting fresh gauze and just clear saliva back to the molars. And then bring one around facially and put one lingually coming up. And now we'll lay the graft in and make sure we like the size. And I'm liking that. So we will insert through the second premolar. Actually could probably insert through the molar. Might be easier. Bet we could. It's a bigger tooth. Put another gauze back there just so I don't touch the tongue with the back side of the graft. It's kind of an exception. It's something you could do, you know, if you have fairly shallow recession, which we do here to a degree in terms of where the papillae are. So this molar, yeah, right there is good. It's a good insertion site. So I'm just going to curve this back. Is that showing okay?
Yes.
So it's pretty easy to get that graft under there, under the margins, what I mean by that. Then I just kind of carry it along and push it with my finger in the vestibule. See if we have a graft showing up there, or right there, you see the graft showing. So I can come in here and grab that, kind of nudge it along, get under the margin. See if I can get it all the way up to that first premolar. And turn to your left a little bit more, I think it'll show better. Is that showing okay?
Great.
So insert graft over the canine. So we have the graft here over the canine as well. And I think you saw the back side of it right there. So I like the positioning, so I'm going to start the suture. I think what I'm going to do with the suture is start at the distal of the molar, so I can coronally advance it. Not there's a great need for it, but then I can catch this the graft at the mesial of the molar when I come back. Just kind of makes it more stable, and we're able to get most of the canine included as well. So it's kind of optional way to do this. So I'm not doing anything but catching tissue on the distal aspect of the molar. And then I'll pass that through the embrasure. Shannon will pick it up, pass it around the molar back to me, perhaps. While she retracts the tongue and grabs it with the forceps, the assistance forceps. Draw this through. Yeah, turn to your left a little more. And leave a pretty good tail. Now to reach, let's just start over. I'm starting at the distal of the most posterior tooth, so the knot will be there. Most comfortable place for the patient. To get to the distal of the next tooth, I need to go under the papilla, passing the needle backwards very carefully. And in that fashion, I don't compress the papilla. So it's going to be continuous sling sutures that do not cross on top of the papilla. When you pass the needle backwards, it's just a little bit easier. You have to be really careful that you don't put stress on the suture needle junction. So I'm going to engage at the distal root line angle of the second premolar, about 4 millimeters off the margin, exit through the sulcus. You can see it exiting here. Don't grab the needle by the middle. I mean, by the point. And draw it through slowly, and then I'll pass through the embrasure distal to the premolar. Let's see if you can see that. Yes, right here. Shannon will pick that up, pass it back to me. And I'm grabbing that needle without getting the suture with it, because if you did that, you can injure the suture, and it can separate from the needle for that reason too. So this is a sling around the second premolar. We're doing just half of the sling on each tooth. So I need to get to the first premolar. I will go under the papilla, exit in the sulcus very carefully. I want to get this where I can just get the needle. And draw that through. Snug it up a little bit as you go. It's hard to have a good positioning if you wait till the end. Now I'm going to penetrate the overlying tissue. And I'm sorry I didn't mention, we want the graft level with the overlying tissue margin. And then I penetrate through the overlying tissue at the distal root line angle. Turn to your left a little bit. Move to your left. Okay. 4 millimeters off the margin, distal root line angle. Draw it up gently, and then I'll pass back through the embrasure to the lingual. Shannon will capture that, pass it back to me. A little bit of a tight, you want me to do it? I think you already had it. I like to take it away just as she gets it, so I can take credit. This is a two-person process. We take turns on whoever has a better view. Now I'll get the distal of the canine. And just the root line angle of the canine. exit through the sulcus. Draw that up slowly. So that suture should be positioned within the sulcus, as it is. Now pass through that embrasure, and so we're actually suturing 4 teeth. The graft is covering 3 of them, actually including the canine with the graft. Just made sense to do it. Tissue was a little thin. Well, you got it before I could even pass it to you completely.
Got lucky.
It's always good to be lucky. So we draw that through gently, and we've got the tail kind of exploring what we're doing. Curious tail. And now we work our way back. So I've got to, the last tooth that I plan to include, I included the canine with the graft. So now we will get the mesials. And turn to your left for me. A little better light there. That's okay. Good. So now I want to engage, pick up the graft on the mesial. And one thing I started to mention, I think I didn't, is here it just kind of happened automatically. You want this graft to be level with the overlying tissue margin so that you advance both of them simultaneously. So you need to bodily insert the graft generally within the tunnel. And what I mean by generally is sometimes it's aligned automatically, because when you put the graft in the tunnel, it causes it to move. It causes the tissue to move coronally. So it almost comes, the overlying tissue almost comes to the CEJ by itself, and you want the graft at that same location. So we'll go under the papilla now to get the mesial of the next tooth, which is the first premolar. And just be gentle with the positioning. A little bit trickier on the return, but not bad. And now then I'll engage at the mesial root line angle. Shannon's pulling that suture out of the way, because what you want to be careful about is you don't want to pass the needle over that suture and against the tooth. In other words, to catch it between, because you'll either injure it or cut it. And that's always discouraging. So we go through the embrasure. Shannon will pass it around back to me. And you can see we're getting pretty nice root coverage. Again, I don't expect it to stay there. It's not necessary for it to stay there. Because we're doing this for augmentation, not for root coverage in this class 3 setting. Turn to your left a little bit more. Thank you. So I'm going to go under this papilla, exit in the sulcus of the second premolar, and then snug that up a little bit as we go. And you can see how it is advancing nicely. Might get fooled and get more root coverage than we expect, but often it'll settle back. And at the second premolar, Shannon's pulling that suture out of the way. I'll be 4 millimeters off the margin. And these penetrations should be about 3 millimeters apart at premolars, 4 max, so that you're moving the tissue proximally as well as coronally. So you adapt to the CEJ better. And now we'll go through the embrasure, around the premolar, and get the mesial of that molar. Catch the graft at that location. And it just almost came through. See the end of it? There we go, perfect. And that snugs up nicely. Hope you can see that snugging as we go. Now under the patella, and Shannon's catching that suture, so she's keeping it straight, so it's not all bunched up. I think, Liz, you asked about that. And this is pretty get pass under that patella into the molar. And if I had good hands, I could capture it. I'm going to turn my hand this way. It was just a little flat against that tooth. My grip on the needle holder wasn't sufficient. And that's pretty at the molar, so we'll catch this graft here, make sure we get the graft. I believe we did. Didn't injure the suture. And while this wasn't a goal of the procedure, to include the molar, it's easy enough to do it. I don't think it needed to be augmented. I'm gonna let you pass it. Maybe I can. Hold that tongue back. And wait, oh, too fast. She fixed it. She fixed it. I don't know if you saw it, if you were fast enough to see that suture was on top of the lingual cusp with the molar, and sometimes, particularly premolars, it will land there, you won't see it, and that's not a good place for it, of course. So what we do now is make sure everything is snugged up. We'll tug on this really gently. So I get the suture end where we will tie. Just tug on it really gently because we snugged it up as we went. And we'll tie, and the tie is 3 throws clockwise, 3 loops clockwise, and then bring this down to get a tie. Have a little bit of loop there, which I can't see because the light went away.
Lean towards this.
Yeah, turn away. We're stretching you so much that it's hard to know where you're supposed to be. So that will hold when you do 3 throws or 3 loops, however you want to call it. So I'll do a counterclockwise. Almost can see that. Hiding behind the cheek. And one more clockwise. And then we want to trim this with about a 6mm tail. All right, I'll show you that better here in just a second. Good, turn to your left to touch again. We're just going to rinse everything. So I think we have a pretty nice outcome. More root coverage than we expect to maintain. And what you need to do with all sites, but particularly mandibular, is put a rolled up gauze in the base of that tunnel and see if there's any pooling and kind of compress that out. There might be a little bit here, it looks like it. You can't see that, I don't think, but I'll show it to you. I mean, it thinks it looks good. I don't see any, just the fact that there's a little concavity there. If it were full, you'd see that. But I still like to see, there's some coming out a little bit, not much. So we compress that, and then I'm gonna leave a gauze in here, let you close and relax. We've been abused enough. Our next step is to add the Gem 21 to each sulcus. So we want to be sure that there's no bleeding interfering with it, so it's really dry. And I will use the initial instrument that we separate the tissue from the tooth, and just it'll be just a little guide of the Gem 21 into the space between the root and the graft. So Shannon's putting it in there with a little micro point. Same thing on the premolar. Let's use the canine too. So there's graft there. I may as well get a little better healing. We have a little bit of graft right there. Perfect. So you see a little tiny graft right there. Turn to your left a little more. So we know we got it with the suture. That just helps the graft in the rest of the area. Have the graft all the way to here on the canine. So that's just thickened, because that was a little thin looking when we went through there. And I think partial root coverage, but a good augmentation. So that's a site I think that would be good to start with, and I hope you had a good demonstration. I'll be over to talk about it shortly, and I think in the meantime I will turn it over to Craig and Kevin. All right, what do you think?
Great.
You did so
Yeah, it
perfect.
was
Yeah.
fine.
Yeah, we had to stretch you around a little bit. Sorry about that.
Yeah, that's okay. Didn't hurt a bit.